Recording in progress.
A very good evening to all of you. On the eve of the World Tourism Day, on behalf of the Positive Psychiatric Task Force of the Indian Psychiatric Society, we are organizing a national webinar. So today we were having distinguished speakers and panelists amongst us. I am Dr. Ranjan Bhattacharya, the Direct Council member of the Indian Psychiatric Society. I welcome all of you in this session. So let me give you a bird's eye view of the program. So, our convener of the Positive Psychiatric Task Force, Dr. Vidyadhar Mil sir, will give the introductory address, welcome address, followed by our address given by our national office bearers. This is the composition of our task force. Dr. Gautam Shiris Amins is the convener, Dr. Arnob Banerjee advisor. So this will be followed by the prime lecture by Dr. Jk Patel sir, who will deliver his topic is positive psychiatry, does it have a place in clinical psychiatry? So this will be followed by a panel debate. The topic of the debate will be positive psychiatry, not pragmatic in private practice in India. The panelists for the motions are Dr. Vishal Chabra and Dr. Posama Chowdhury, and the panelists against the motion are Dr. Ajit Vide and Dr. Rukseda Saeda. The session will be moderated by Dr. Abir Mukherjee. So this is the tentative schedule of our program. I am the Direct Council member and the MOC as already mentioned. So without much ado, let's begin. So I'd like to now invite our chairperson, sir, Dr. Vidyadhar Mil, to give his welcome address.
Am I audible?
Yes. Yes, sir.
Good evening, friends. I welcome you all for today's webinar on disease management from happiness to holistic approach. Positive mental health refers to presence of positive emotions and good functioning in both individual and social environment. There is a growing interest in understanding and enhancing positive mental health and well-being, particularly from development in the field of positive psychology and mental health promotions. Positive psychiatry is a new term that describes a dual approach to mental health, where we could build strength, support, and healthy lifestyle, as well as treating illness and distress. As we all are aware, that positive psychiatry deals with master strategy and tools that enable individuals and organizations to thrive. Discover key theories and research in the field of positive psychology, as well as opportunities for application. Apply key concepts from positive psychology to personal and professional life, and understanding the scientific foundation of positive psychology. So without wasting much time, I would like to invite national office bearers to take up the platform. Thank you.
Thank you, sir, for your brief welcome address. May I invite the President of Indian Psychiatric Society, Dr. Gautam Shah, sir, to give his introductory comment.
Thank you, Ranjan, Dr. Ranjan Bhattacharya. It's a really great privilege to be here today. What a beautiful concept. Actually, I must thanks to who brings this positive psychiatry in this subcommittee group, because it is so important. And it happens to be, I think, in the year 4 years back, we include this committee in this Indian Psychiatric Society. I am really glad that all the office bearer, the Vice President, esteemed Dr. N.N. Raju, Dr. T.S.S. Rao, Dr. O.P. Singh, and Dr. K.K. Mishra is here with us. And at the outset, I also congratulate the total team of Positive Psychiatry Task Force, which includes Dr. Vidyadhar Mil as a chairperson, Dr. Sanjay Kumar as a co-chairperson, and convener none other than he is also Gautam, Dr. Gautam M. Sarin, my dear friend. And advisor is one of the senior most psychiatrists of Bengal, Dr. Arnob Banerjee, and EC coordinator is the most dynamic member of our society, Dr. Ranjan Bhattacharya, my brother. And also today, we are getting esteemed panelists and speakers like Dr. Jk Patel, who is the speaker today, and the panelists includes Dr. Ruksheda Shaida, Dr. Bishal Shabra, our past president, Dr. Ajit Bide, and Dr. Posama Chowdhury. And moderator is none other than one of the most efficient psychiatrists now in Indian Psychiatric Society is Dr. Abir Mukherjee. So my dear friend, you know that whenever we discuss positive psychiatry, it is really great that we should know what is positive psychiatry. If you want, because the positive psychiatry is conceived as the applying positive psychology tools to help those with or at risk for mental disorders. It has been defined as the science and practice of psychiatry that seeks to understand and promote well-being through the assessment and intervention aimed at enhancing the behavioral and mental illness. Most important is the happiness. It includes the enhancing the positive psychological factors among the people who have or are at the risk of developing mental or physical illness. My dear friend, there are positive psychological factors which include psychological traits, environmental factors that mediate the positive outcomes such as the well-being, growth, and the flourishing. All these things, ultimately our goal to make happy to that person, which actually improves their mental health, as well as if the people are suffering from mental illness, it definitely helps to heal their problems. And if you make a list of 6 major virtues of the positive psychiatry, which includes the wisdom, courage, humanity, justice, temperance, and the transcendence. This component, each virtues are very important, and I'm sure our esteemed speaker and the panelists will do justice and they enlighten us regarding all these factors. And I don't want to take much time, and everybody is eagerly waiting to listen to them. Thank you so much. Thank you again, this committee task force for doing excellent job. Thank you so much. Over to Ranjan.
Thank you so much, Mr. Thank you so much, Mr. President, sir, for a bird's eye view of the positive psychiatry. From your perspective, very rightly you have pointed out certain aspects. So may I invite Dr. Nadakuru Raju, sir, the Vice President cum President-elect of the Indian Psychiatric Society, joining from Hyderabad, to give his introductory comments. Dr. Raju, sir.
Yeah. Am I audible?
May I invite Dr. Raju, sir?
Yeah. Yes. Am I audible, Ranjan?
Yes. Clearly and loudly.
Thank you. Because Ranjan's voice was disturbing, so I'm not very sure whether the disturbance is from your end and my end. Thank you, Dr. Ranjan, for inviting me. Our President, Dr. Gautam Shah, and my colleagues. Quite a good evening and quite a rainy day here in Vizag. I'm not very sure how it is on the other parts of the country. It is raining heavily. One of the heaviest rains we had for many years. And when I saw the topic today, the positive psychiatry, for a change, a bit I was wondering whether it is an oxymoron. So I had a doubt after 40 years of being in psychiatry, went back to Google and saw what psychiatry really means. So then I realized that it is just the study and treatment of mental illness. So again, now we are talking about the positiveness in the treatment and mental illness. Are we aping from positive psychology? We do not know. But one thing is very sure, that if it means the mental health, I'm sure we need to understand that we need to know what exactly it means. We also need to know what exactly we can do, apart from what the regular suggestions of having a schedule, getting up early in the morning. It is like Rama is a good boy type of behavior. Is it the positive psychology or something, psychiatry or something? Today we are going to learn all that, and perhaps today is the day where I would be starting with zero and really listen to all our esteemed speakers. It has been, if you see the list, this is something who is who and brilliant speakers. And just for the sake of the speakers, I would be sitting right throughout the program, irrespective what they speak. So, and also the team itself is a brilliant team we have, as Dr. Gautam said, Dr. Vijay Meal, Dr. Sanjay Kumar, Dr. Gautam Amin, Dr. our own Dada, Dr. Arnav Banerjee, and of course, nothing, I think the most handsome EC member, Ranjan Bhattacharya, coordinating everything. So it's going to be a brilliant, brilliant evening for me. And I think the panelists too are no less handsome, with heading by Dr. none other than Ajit Bide, who can run money for any actor run for their money. So we have Dr. Syed, Dr. Vishal, Saida, and then Vishal, then I think Prathama, everybody. I think they are literally the crew of any Hollywood movie or a Bollywood movie, something like that. I think they can easily fit into any of, all of them can fit into any of these things. And of course, no less is moderator Avir Mukherjee, equally handsome, equally charming individual today. And I think this is the best day to be. I think I don't know whether all lady members know today's member list. I think they would all of them would have glued to the screens. Anyway, thank you so much for giving me this opportunity. Good day. And have a great day. I'm here listening to you all, guys. Thank you so much. Best of luck. Over to Ranjan.
Ranjan is there or net is making problem?
He's not there.
Can I start with the introduction of Dr. Patel?
Dr. Gautam, please, you continue.
So
I'm here and I wish the conference all the success, Dr. Rao.
Hi, hello, sir.
Sorry, got a little delayed because I was climbing the stairs to reach home. Fine.
Welcome, Dr. TSS Rao. Okay, so it's a great pleasure for me to introduce the speaker for today evening. Dr.
Dr. Gautam, please, Dr. Kiroj Mishra and Dr. O.P. Singh, if they are just take their...
Okay, I'm so sorry.
Dr. TSS wants to speak.
Hello.
Okay, Dr. TSS.
No, I just wanted to... When I heard our VP speaking about all the men charming and this thing, I was suddenly getting some doubts.
But you are not there. You are not there. That's why you are missing.
The last sentence you added, ladies. But anyway, I love this word positivity and other related things which are there. Love and laughter are the best medicine on this earth. So all the best for the program.
Thank you.
Thank you, Dr. Rao.
Thank you.
Dr. O.P. Singh, sir, would you like to say something? Dr. O.P. Singh, sir.
O.P., unmute yourself.
Okay. Dr. K.K. Mishra, sir.
Yeah, I'm seeing him.
Yeah, good evening. O.P. sir is not there? I think I'll just speak for a few minutes. And then...
Yes, sir.
Yeah, good evening, all the esteemed peace bearers of the Indian Psychiatry Society, starting from President Dr. Gautam Sir. Vice President
Dr. I'm audible? No.
Yes.
You're audible.
You're audible.
Sorry. I'm audible? Okay, yes. My best wishes. Thank you.
Okay, all the esteemed members of the task force, starting from Vidyadhar Mil sir, Dr. Gautam Amin, and the most dynamic Ranjan and Anurda and Sanjay, and we have got all the esteemed speakers for today's panel discussion and debate. So I'll not waste much of the time starting in the process. Professor Bhide sir and Dr. Patel, Fatima Madam, Vishal and Saida, they're all actually well known in their field and in the areas of domain interest, and all the senior members of Indian Psychiatric Society and all my good friends. And at the onset, I wish you all the best for the task force. I will not extend further. And already President, Vice President have given the brief introduction about the topic. Instead of wasting much time, we'll listen to the esteemed speaker. Thank you very much for getting us here, and good evening to all of you.
Thank you very much, Dr. K.K. Mishra, sir. Is Dr. O.P. Singh around, sir? Dr. O.P. Singh?
Good evening to everybody. This is going to be really wonderful program. And as Dr. Raju has said, very glamorous brigade led by our past president, Dr. Bhide, then Dr. Ruksheda, Dr. Vishal, and Dr. Pathma. And I thank all this committee, Dr. Gautam Amin, Sanjay Kumar, Dr. Vidyadhar Meel, Advisor Dr. Arnabda and Ranjan for this program. And we like to listen to this with the entertaining debate. I know the people involved here are such a sharp people. So we will be enjoying. Thank you. My best wishes.
Thank you very much, Dr. Singh. I will now introduce you to the speaker, Dr. Jk Patel. It's a great pleasure for me to introduce him. First of all, I thank him from the bottom of my head for accepting this invitation to speak here and taking time out from his busy schedule. Dr. Jk Patel was born in Tanzania, East Africa. He completed his basic medical education and residency in psychiatry from Baroda Medical College, MSU, Vadodara. After that, he worked in Dar es Salaam as a psychiatrist, where he was a lecturer in psychiatry at University of Dar es Salaam in 1997. As well, he was in charge of the psychiatric rehabilitation village. Dr. Patel completed his psychiatry residency and a fellowship in research and schizophrenia at Massachusetts Mental Health Center, Harvard Medical School. He received numerous fellowship awards from Harvard Medical School and American Psychiatric Association between 1992 and 94. He was medical director of the Commonwealth Research and Evaluation Unit, Commonwealth Research Center, Harvard Medical School for 7 years before moving to University of Massachusetts Medical Center in 2000. Dr. Patel was director of schizophrenia research and director of bipolar disorder programs at the University of Massachusetts. He was site principal investigator for many NIMH-sponsored studies, including the KT schizophrenia study and the STEP-BD study for bipolar disorders, the largest studies of their kind ever funded by NIMH for these disorders. He belonged to a select group of researchers who were invited to form the NIMH-supported Schizophrenia Trials Network, the STN, involved in implementing large, clinically important psychopharmacological trials in schizophrenia. Dr. Patel has received numerous awards, including the annual Paul Barrera Award for Excellence in Teaching 4 times from the psychiatric residents at University of Massachusetts. He received the Irma Bland Award for Excellence in Teaching residents from the American Psychiatric Association in 2006. He was director of the Resident Psychopharmacology Clinic at UMass. He has published more than 100 academic papers, book chapters, etc. He has been recognized by best doctors in America since 2009 and by best doctors in Louisiana since 2011. Dr. Patel received the prestigious Mercy Award from the Lake Charles branch of National Alliance for Mental Health in 2016. Dr. Patel moved to Lake Charles in 2010 and is a staff psychiatrist at Lake Area Psychiatry, Lake Charles. He is a medical director of geriatric unit at St. Christus Patrick Hospital, Lake Charles, Louisiana. He is a medical director of Kingdom Express since February 2017. He is medical director of SOP program at St. Christ's Patrick Hospital, Lake Charles, Louisiana. So this was an introduction. I invite Dr. Jk Patel to please enlighten us on this topic, positive psychiatry, which as all the majority of us are not aware, though this being a old concept, but in India, for us, it is going to be very, we are going to gain knowledge. We'll know something about what is positive psychiatry. Dr. Patel, please.
Good evening there. I hope you can see the slides. Can you?
Yes, sir.
Yeah.
Oh,
Yes.
Dr. Ranjan is back.
Sorry?
Dr.
Yes.
Ranjan is back.
Yes, sir. Please go ahead.
Okay. Once again, thank you so much for inviting me to talk today. I'd like to thank the organizers. Having been trained in India and then subsequently trained again in the United States, I have had the pleasure and I've been fortunate to have met so many field leaders, worked with them, interacted with them, and learned from them. When Dr. Gautam Amin asked me to do a presentation, I did not realize it was going to be at the national level. And I took up the topic of positive psychiatry, even though I come from the field of biological sciences, clinical pharmacology, and this is not an area of my expertise, but I'll tell you later why I chose this topic in a few minutes. So positive psychiatry essentially is a tale of two presidential addresses. One was Martin Seligman, who was a psychologist, and he gave the presidential address in 1998, and essentially promoting the concept of positive psychology. And then it was Dr. Dilip Jeste at American Psychiatric Association 2012 presidential address, where he promoted the concept of positive psychiatry. These two presidential addresses are remarkable because while they were not their original concepts, they highlighted what was being discussed in the background, or everybody recognized how important these concepts were. So Martin Seligman, again, is a family professor of psychology, and he's considered to be father of positive psychology. It's very interesting how he came about with this whole concept of positive psychology. While he was gardening with his daughter, who was 5 years old, she was trying to get his attention, and he snapped at her. And what ended up happening was that she brought to his attention that when she was 3 or 4 years old, she stopped whining at age 4. And if she can stop whining, then he can stop being a grouch at his age. A very solid endorsement by his daughter. This started him on a path of positive psychology, and he later articulated that we should teach our children and ourselves to look at our strengths rather than our weaknesses. So he was coming from the field of psychology where there were some negative focuses from his perspective and his colleagues' perspective. They were creating some drawbacks, one of them being that psychologists were becoming victimologists or pathologizers, and they forgot that people make choices and have responsibility. They forgot about improving normal lives and high talent. In their rush to repair the damage, it never occurred to them to develop interventions to make people happier. So positive psychology, what is it? It is a study of human beings prosper in the face of adversity. Its goals are to identify and enhance the human strengths and virtues that make life worth living and allow individuals and communities to thrive. Many psychologists were unhappy with the disease model of psychology, as they maintain that all people have innate tendency to strive for perpetual growth and development. This is important because for a long period of time, there was a tremendous focus just on the pathology and the suffering or the shortcomings of the individual rather than also focusing on the strengths of the individual. So an example I can give you is, and that can play an important role throughout the discussion, is that if you have paralysis or decreased functioning of your right hand, you need your left hand to help you to overcome the deficit in the right hand. Even though your left hand is normal, then no problem with that. And the point being that if you just focus on the right hand and do not use the left hand, you're missing out. So it's a concept of working with the health and the healthier aspect and promoting that while also focusing on the deficit or the diseased part of your body. So they believe that the central concerns of psychology should be positive phenomena such as love, courage, and happiness. Now let's talk about Dr. Dilip Jeste. Most of you should be aware of him. If not, he is one of the most accomplished psychiatrists who was born in India and did his psychiatry in India. Currently, he is the Estelle and Edgar Levi Memorial Chair in Aging. He's also director of Sam and Rose Stein Institute for Research on Aging, a distinguished professor, of course, but he's also the past president of American Psychiatric Association, 2012 to 2013. He was the first Asian American to preside over this 175-year-old organization. He was also the first psychiatrist of Indian descent to be elected to Institute of Medicine and National Academy of Sciences. He studied medicine in Pune, and he's a psychiatry at KEM Hospital in Mumbai. He played a very critical role in promoting and making positive psychiatry an important component of contemporary psychiatry. He designated the year of his presidency as the year of positive psychiatry. He's a prolific writer, a researcher on this topic. He has also published 4 books already on this topic. So what is positive psychiatry? And also the corollary would be that if we say positive psychiatry, does it mean that there is negative psychiatry? So positive psychiatry, as Dr. Saha and other people articulated so well, is the science and practice of psychiatry that seeks to understand and promote well-being through assessment and interventions aimed at enhancing behavioral and mental wellness. Key constructs in positive psychiatry include both positive mental health outcomes and positive psychosocial characteristics, or PPCs. The main objective is greater well-being, which may be achieved through optimal increase in key PPCs such as resilience and social support. So let me give you another example here. So if somebody develops, let's say, depression, so they go from 0 to -7, psychiatry attempts to bring the person back to 0. Positive psychiatry enhances that by trying to get the person to be +2 or +5. So positive psychiatry is not a kind of a different psychiatry as much as it's augmentation of what we do clinically right now. But it is not just focusing on the illness, but also focusing on the positive health. As a branch of medicine, Positive psychiatry is rooted in biology and seeks to decipher biological underpinnings of PPCs and eventually promote health and well-being through psychosocial behavior and biological interventions. Essentially, this is not just to make patient feel good. It's not like being nice to the patient. This is more than that. This is to look for what are the PPCs in a person and promote them to enhance a person's well-being, independent of or in collaboration with whatever psychopathological issues they may have. And it should be treated just like you would treat any topic in the field of science. It should undergo research. There should be clinical determinants, and as much as possible, ways to manipulate them to optimize a person's health. Just quickly, I realized that this was almost like a TED Talk format of 20 minutes to 25 minutes to tackle this such an important topic. And I had to learn how to do something that you would do in 1 hour in 20 minutes. So you guys will have to forgive me if I don't cover everything. And also, I would like to make sure that people understand I'm just like one of you guys, just a little bit more experienced perhaps, and I will not be able to answer all the questions you might have. But my goal today would be to just be able to understand a few things here and to think if they can be applied in your clinical practices. So positive psychology and positive psychiatry are not competitors, but allies. They are partially overlapping in their concepts and goals, but each bring its unique training background and skills. We have to talk about health first. So what is health? So WHO defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. Higher levels of positive psychosocial characteristics such as resilience, optimism, social engagement are associated with objectively measured better health outcomes, including greater longevity as well as subjective well-being. I'm going to take a little bit of a tangent here, maybe take a couple of minutes. And Dr. Ranjan will forgive me if I overshoot the 20-25 minutes mark. So why would somebody like me be interested in concepts like this when I was and have been focused just on the disease part or the pharmacological part of treatments? We have come a long way since psychiatry was introduced as a medical field. We have come a long way in having patients who are in asylums. Initially we had successes with penicillin and getting a lot of patients with tertiary syphilis get treated and get discharged or sent back home. Also, the revolution, the first psychopharmacological revolution with Thorazine, allowed for deinstitutionalization when John F. Kennedy in 1963 signed this in as a right of every mentally ill person to be able to live in the community and prosper and reach their God-given potential. Since then, we realized that medicines were still not great, and then we had clozapine revolution. The field of depression had its evolution with tricyclic antidepressants, and then subsequently the field changed dramatically with Prozac. The field of bipolar disorder had its dramatic changes post-lithium and the newer mood stabilizers. So the field has come a long way. We have been very successful in achieving a lot in the field of psychiatry. But there are still so many things that are not going well. So for example, when we did the KT study, the STEP-BD study, the STAR-D study, and other studies that were sponsored by NIMH or other non-pharmaceutical companies, what became very clear was that we are very good. Our medications are good, but they're not good enough in the sense they do not help everybody, and we still do not know which medication should be used first. And psychiatry treatments or psychopharmacology is often an art than a science. Also, even after so much knowledge, research data, we still don't have a test that can determine if somebody has schizophrenia, bipolar disorder, depression, anxiety disorder, etc. We still do not know exact biochemical underpinnings of brain disorders or mental disorders. We know that serotonin, dopamine, and other biochemicals play a role, but we do not have a specific etiological connections to these neurotransmitters or neurohormones. Furthermore, we had great expectations from the genomics and the genetics programs. We had great expectations from the decade of brain or mind in 1999 to 2000. And subsequently, we also had tremendous expectations from proteomics and metabolic markers and things like that. But unfortunately for us, it has not panned out the way we'd like it to. But we also realized that we were too medication illness focused, and we were not recognizing the potential that individuals have. A person like Dr. George Valent, who I admire a lot for all the contributions he has made, helped us understand that human brain continues to grow. It does not stop at age 6 or it does not stop at age 40. It is a resilient organ, and it can change and adapt, and there is a lot that goes on even after age 50, 60, 70. And Dr. Dilip Jeste, through his studies and his focus on wisdom, has also shared with us that there is neuroplasticity occurring around ages 80, 90 also. And my point being that the human connection, the relationships, those factors are as important perhaps as the psychotropic medications are. So well-being. So well-being is not merely an absence of mental and physical disorders, but the presence of positive psychological state, such as life satisfaction and happiness. It contains elements conducive to happiness and well-being, including purpose in life and self-acceptance. Well-being is associated with greater longevity in modern economics, which again is very important. Well-being is considered a measure of national development. Low level of perceived stress. Perceived stress indicates the degree to which an individual believes that his or her contemporary demands or challenges exceed his or her ability to cope. Just to be glib a little bit, my perceived stress yesterday was significantly higher, and it is dissipating as I'm talking about these issues today. Perceived stress is reportedly more critical than objective measure of stress in its impact on biomarkers such as telomere length, meaning that subjective acknowledgement, subjective indications of perceived stress are as important and perhaps more critical than objective measures of perceived stress. Successful psychosocial aging. So we have to think about positive psychiatry across the lifespan. The whole concept goes right from the early stages of infancy all the way to old age. And it should also include the fetal environment when a person is pregnant. So it's a broad, very large area, and it should be so that way. Older elders considered the ability to adapt to circumstances and positive attitude towards the future to be more important than an absence of physical disability. This is an interesting concept promoted more by Dr. Dilip Jeste, when he realized that as people were getting older and they were becoming physically more not able to do things, their mental health overall was significantly more positive than their physical health. And there was kind of, that kind of didn't make sense to him. And that's what got him to dig deeper into what all this means. This may explain a well-documented paradox of aging. Even as physical health declines, self-rated successful aging tends to be higher in later life. A bottom line here being that do not disregard and discard older people. They have a very important role to play. Post-traumatic growth. I'll talk about the Chinese saying that every disaster is an opportunity to do things differently. So severe stress is sometimes followed by PTSD. However, some stressed individuals experience personality growth. PTSD, post-traumatic growth, reflects an individual's resilience in the face of severe stress and may be manifested by greater appreciation of life, altered priorities, closer interpersonal relationships, greater sense of personal strength, and recognition of new possibilities for one's life. So every negative experience is not necessarily negative. There can be some positive out of it. How are we doing? Okay. Recovery in serious mental illness. Even among seriously mentally ill individuals, there can be wellness within illness. Although professional versus consumer definitions of recovery differ in terms of requiring symptom remission, both acknowledge the importance of independence and reduction of impact of illness on one's life. There's a book written by a psychologist and a psychiatrist called The Center Cannot Hold. She, while suffering schizophrenia, became a lawyer and a psychiatrist. And she accomplished a lot even while suffering from severe mental illness. So there are positive components to an individual, even when they suffer from mental illness. And that's why perhaps it's better to say a person with schizophrenia rather than saying he's schizophrenic, because a person with schizophrenia means that there is more to a person than just having mental illness. Many individuals struggle with mental illness have led outstanding lives of courage, dignity, and contribution to society. We often applaud cancer survivors, but we very seldom talk about people who are struggling daily with bipolar disorder, depression, or psychosis. We seldom call them as brave or dealing with such an enormous stress and coming out of it every day and dealing with it on a regular basis and calling them as warriors or heroes. People with non-remitted chronic schizophrenia can also experience happiness. Prevention of mental illness. So prevention has a long history in the field of community psychiatry, including primary, secondary, and tertiary prevention. Such efforts are mainly focused on youth, but recently we have expanded that in adult areas such as postpartum psychosis, PTSD, post-stroke depression, and even dementia. There's also been focus on first episode psychosis, where you try to intervene effectively so that you can prevent the downhill course that we typically see in schizophrenia. Empirical research supports a model in which positive psychological traits interact with and feed into each individual's evolution of his or her degree of well-being and are stronger predictor of well-being than his physical health. Several such traits have been shown to have a positive impact on longevity, with effect sizes that rival or even exceed those of well-established health risk factors such as smoking, hypertension, and obesity. This is very positive, and it's very important, again, to recognize the value of such traits. So resilience. It refers to ready recovery from or positive adaptation to illness or other adversities. Resilience and optimism are associated with a lower risk of all-cause mortality. Among physically ill patients, resilience is associated with improved physical health, health-related quality of life, self-care, treatment, and exercise adherence. Resilience is also associated with better control, better emotional health and well-being, less pain, and better health-related quality of life in older adults. Among people in their 90s, those who endorsed higher levels of resilience had a 43% greater likelihood of living to 100 years age. Optimism, again, reflects a tendency to expect good outcomes. Optimism should not be confused with denial. It has been studied in context of serious medical conditions, has shown to be associated with less illness-related distress, higher quality of life and satisfaction, and lower incidence of depression. In meta-analysis of 83 studies, again, optimism found a significant relationship between optimism and better health outcomes. That includes cardiovascular outcomes, physiological markers, cancer outcomes, pregnancy, pain, and mortality. Optimistic adults are more likely to engage in healthy behaviors than pessimists. Dr. Ranjan, if you're listening, tell me when to stop if I'm exceeding those 25 minutes, okay?
You can jolly well go for 7 to 8 minutes. Sir.
Okay, all right.
Fine.
So personal mastery and coping self-efficacy. Again, another very important characteristic for mental health management. Personal mastery denotes one's expectations of personal effectiveness in achieving desired outcomes. This often makes me think of Amitabh Bachchan, like, making his powerful dialogues, like, line wahan se shuru hoti hai jahan hum khade rehte hai, things like that. In a context of chronic life stress, personal mastery may promote specific, adaptive, goal-oriented behaviors, as well as aid in the maintenance of those behaviors despite ongoing stresses. Again, personal mastery seems to protect individuals from negative health effects. And there is a related concept of coping self-efficacy, which refers to self-perceived ability to activate specific coping strategies to overcome life challenges and to influence outcomes. Social engagement. This is a very important component. I talked about Dr. George Valent. He, a remarkable psychiatrist, was in charge of the grant project, which was when he was at Harvard, which actually is still at Harvard. He prospectively studied a large group of adults, and the study is still ongoing. And then there was a comparator arm of people who were living in the neighborhoods with limited opportunities, resources. And at the end of a very long duration of study, 50 plus years, social engagement came out to be a very important predictor of happiness, not making money or achieving richness. So social engagement, again, is a very important aspect of positive health. This includes not only the number, but the quality of close relationships, frequency of socialization, and degree to which one finds pleasure from social integration and interactions. Quality and quantity of one's social relationships are associated with health outcomes across a range of medical populations. And again, large studies have shown how strong social relationships have a dramatic impact on so many health outcome measures. Spirituality and religiosity. So spirituality refers to the degree to which one's personal beliefs, thoughts, and behaviors focus on transcendental topics such as meaning of life, belief in a higher being, and power or level of consciousness. Again, religiosity, again, it refers to organized religion and also has an inherent social connotation, whereas spirituality can be personalized. Spirituality is more personal, religiosity is more generalized. And again, they are associated with greater well-being and better health outcomes throughout one's lifespan. Wisdom, a very important concept. Despite variability among definitions of wisdom, common elements include pro-social behaviors, which is compassion, empathy, altruism, social decision-making, insight, decisiveness, acknowledgement of uncertainty, emotional regulation. Dr. Jeste and his groups and others have done excellent studies on issues like wisdom and higher functions. What seems clear is that amygdala, which is one of the oldest parts of brain, and neocortex, frontal lobes, are the newest part of the brain. In younger folks, it seems that amygdala is much more active. And in older folks, it seems like the prefrontal cortex is more active. And it seems that the balance between prefrontal cortex and amygdala and how it is managed perhaps underlies wisdom. So emotional regulation, again, a very important characteristic. Being tolerant of divergent value systems, openness to new experience, spirituality, and of course, a sense of humor. So what unites these components is their usefulness for the self and for others. Greater wisdom may be important for an older adult's ability to survive and even thrive in spite of worsening physical health. Similarly, wisdom transmitted to younger generations may provide a fitness advantage and help to neutralize the loss of fertility in old age. Again, I'll not go into the grandma hypothesis right now, but we can talk about it later. Wise people are intelligent, but not all intelligent people are wise. Other factors are also part of positive psychiatry. Gratitude is an important factor to talk about for a minute. It comes from predominantly the Alcoholics Anonymous system. Love, joy, all of these are also important components. So let me discuss quickly a case that's reported in Positive Psychiatry, which is a book by Summers and Jeste. And this is a case by Dr. Wahia and Dharmadhikari. And they discuss a strength-based approach to the psychotherapeutic management of schizophrenia. Very briefly, This is a 45-year-old divorced Indian female suffering from schizophrenia and was deported to India from New Zealand. She was treatment non-compliant and had multiple hospitalizations in New Zealand. The authors were able to develop a positive rapport with the patient, improve her treatment compliance, help her share her inner thoughts easily, clearly while focusing on rehab. Her biological family, her ex-husband and children were able to be supportive. Her family and local community helped her regain her pre-morbid skills, return to work, regain her confidence, and overcome stigma. She started exercising, improved her social skills, and thus improved her quality of life. The authors, of course, there's a lot of details to this case, which unfortunately I cannot describe here. But the authors opine that taking the what next approach, instead of trying to find faults with her family, were very helpful. There was a proactive approach to rehabilitate the person to reach their God-given potential, including what her pre-morbid skills were, which was in the field of accounting, and to help her return to work under supervision initially, and then regain her confidence and keep her symptom managed and also out of hospital. So can positive psychiatry work in clinical setting? Of course, this is a rhetoric question. It does and it can work in clinical setting. Positive psychiatry augments current clinical work and does not replace it. One can adapt to their circumstances and spend as little or as much time as one can manage. They're here being patients. The point is that we as a clinician can often ask the question, is this going to mean more work for me? Is it going to mean that I'll be spending more time and not get paid doing what I do with the patients? And the answer is yes and no. It depends on you. It depends on where you want to go with this. And you can spend a little time, big changes in a person's life. And the next question is, can it work in Indian clinical setting? India clinical setting is very different from American setting, where American setting is dictated a lot by insurance. Indian setting does have insurance component, but Indian setting also has a very different payer mechanism. And I will let this question be addressed by the panelist members. And I'm going to stop here. And again, thank you very much for patiently listening to me. Sorry to have exceeded the time if that's the case. And I'll hand over the mic to the conveners.
Dr. Gautam, sir, please.
Thank you very much, Dr.
Please take
Patel.
the session, ask question.
I have a few questions asked by the audience. Disorder or disease, which term is more appropriate in case of psychiatric illness?
So I think I covered a little bit in my discussion when I was saying that so far we do not have a single test to be able to diagnose schizophrenia, bipolar disorder, etc. The disease concept requires closing that loop. And as a result, it would be more appropriate to call psychiatric conditions, most of them, not all of them, most of them as disorders rather than disease. Often we use this term interchangeably, colloquially, but for academic reasons, we could go that direction.
Thank you. Holistic, does it start from etiological factor and includes pharmaco and psychological therapy till recovery to back to work?
Holistic concepts were strongly promoted through the humanistic psychology, where they deviated from and they moved away from the behavioralism and psychoanalysis, and they wanted to address the whole human being and not the part, because they believed that the whole was much better than the part. The criticism directed towards a holistic approach sometimes is that it is very difficult to apply research methodology to holistic paradigms. And there is a lot of debate in the field about that. In a very different way, the way I would answer that question is that we, of course, have to zone into a person's pathology or whatever's troubling them. But we also, instead of having a microscope approach all the time, we can have a telescope approach where we can look at the whole person, look at what constitutes the positives and negatives of the person. If we require to work with the patient, working with their strengths allows them to participate much better than working against their strengths. And when you look at the holistic thing, it should include the spiritual, the psychopharmacology, and everything. I think the most important component often is to make patient part of the treatment team rather than have things being done to the patient. I hope that answers the question.
Yes. So the next question is how to apply positive psychiatry in day-to-day life.
So it is trying to meet the person where the person is. And the second part of it is to figure out what are the strengths of the person. And in order to do that, one does need to understand the person better rather than apply your own judgment into a person or onto a person. In day-to-day life, what is it that makes them go? What is it that makes them work? Think about it. If you have cancer, cancer can limit your life. If you have pneumonia, pneumonia can limit your life. But the pneumonia is short-lived. When you talk about mental illness is a chronic illness. It affects people in their prime, and it's a relationship of 30, 40 years we're talking about. So we have to figure out what makes you tick when you wake up in the morning. What makes you keep on going? What are your aspirations? What are the things that you value? I think that is where it becomes difficult because you have to spend time to understand the person. So I think it is very possible to do day-to-day. It is very possible to apply in a day-to-day living situation, but you have to be honest about it and authentic about it. It cannot be superficial and just do because you want to feel good that you are applying positive psychiatry.
Okay, the next question is, what is the difference between happiness, joy, and bliss?
Let's do this. Let's punt this question to the panel.
Panel.
Yeah, okay. Panel and see.
And okay. And I think the last question is how to increase resilience, optimism in a patient.
Very good question. I think some of it will be covered in our panel discussion. Basically, what I would say is that start with recognizing what they have. And we can take the example of somebody who has a right hand that is not working and the left hand is the normal hand. How do you make the normal hand work better? So I think it is trying to recognize where the person is and then trying to work in increasing their resilience. There is nobody who does not have resilience. I think that's the starting point. And the question is that where is the person when it comes to making adaptations? Where is the person when it comes to making accommodations? And trying to meet the person where they are, but being mindful of the concept of resilience. It's a great question. I'm sorry if answering it in a way that's incomplete.
And optimism.
Optimism, yes. Again, optimism is not being dishonest about the reality. Optimism is not just being in denial. Optimism is being able to figure out a way to be on top of the issue rather than be consumed by the issue. Optimism is to find a way to tackle this head on with an attitude that does not give in, but it tries to figure out that, okay, I've been given lemons. Let's see if I can make some lemonade out of it.
Thank you. Thank you very much, Dr. Patel, for simplifying such a complex topic. If any more questions, Dr. Ranjan, you might have it. I don't have any more questions. It's over to you, Dr. Ranjan.
Yeah, I don't have any further question. Thanks for this fascinating, wonderful, and insightful session, Dr. Jk Patel, sir. And thanks for taking so much pain for delivering the lecture from a different time zone, taking all sorts of pain for us. Thank you so much. So please do stay with us. We are now in the midway of our webinar, and we'll be amazed to know that in the both platforms together, around 192 people are watching this right now. So without much ado, I'll move to the most interesting part of the session right now. That is the debate. So just to show the topic of our debate, the positive psychiatry, not pragmatic, in private practice in India. Moderator of this debate session will be Dr. Abir Mukherjee, who has graduated from Jk Medical College, from where the GHP has been set up first, you all know. He has done his MD, DNB, and MRC Psy and CCT UK. He's a consultant psychiatrist. He is currently attached as a senior consultant psychiatrist at Medical Superspecialty Hospital. He's also the visiting consultant psychiatrist of Amri Group of Hospital, involved actively in training in field clinical work with an NGO called Ishwar Sankalpo, who are caring for the homeless mentally ill. His areas of interest are developmental disorder in children and adults, rehabilitation psychiatry, and neuropsychiatry. He has many achievements to his credit, and he is a member of the Royal College of Psychiatrists, Life Fellow of Indian Psychiatric Society, and West Bengal Medical Council. The panelists for the motions of this debate are Dr. Vishal Chabra, who is the president-elect of Delhi Psychiatric Society. He is also the co-chairman of IPS Headquarters Committee, senior consultant secretary of Fortis Healthcare, Delhi. And Dr. Posama Chowdhury, who has graduated from Calcutta Medical College, done her MD from the Central Institute of Psychiatry. She received a fellowship from the New South Wales Institute of Psychiatry, Sydney, currently attached as Professor of Psychiatry of Calcutta National Medical College, Kolkata. She is the convener of the Psychotherapy Subcommittee of Indian Psychiatric Society. She is a renowned speaker in various national and international psychiatric conferences, school, college mental health programs, and she has quite a few publications in peer-reviewed journal. The panelists who will speak against the motion are Dr. Jk Patel, Emeritus Consultant in Psychiatry, St. Martha Hospital, Bangalore, where he has been working for the last 34 years and had introduced the family medicine PG program there. Dr. Patel had been the past president of the Indian Psychiatric Society in the year 2018-19. He has chaired the Ethics Subcommittee, Advocacy Committee, Boundary Violation Task Force on LGBT mental health IPS in past, and also the literary editor of the Indian Journal of Psychiatry. And he had been the former president and CME chair of the IPS South Zone and former secretary editor and president of IPS Karnataka. She is a very prolific and popular speaker at public and professional forum, and he's an area of interest to many, you can just see, and he has 27 publications to his credit and more than 40 CME presentations. And finally, Dr. Feda Rukshada, we all know her. She's a very eminent psychiatrist and psychotherapist and serves as a co-chair of the Women's Mental Health Specialty Section of Indian Psychiatric Society. She is the Executive Council member of the Indian Association of Private Psychiatry, National General Secretary of the Indian Association of the Biological Psychiatry. She has authored many academic articles and chapters and is a keen teacher. Right now, she wishes she was on a vacation and marks were a thing of the past. We all dream so. So with this, let's begin. Over to Dr. Abir Mukherjee.
Thank you, Ranjan. Thank you so much for your introduction, and thank you for the Positive Psychiatry Task Force to invite me to moderate this excellent panel. Excellent debate. And when Dr. Ranjan Bhattacharya invited me, I was wondering that do I know anything about positive psychiatry at all? And then I sort of read through, and I was so fascinated with this whole concept. And today, Dr. Patel has elucidated very, very eloquently about the positive mental health outcomes, the well-being, as well as the positive psychosocial characteristics, giving importance to each and every point. He has also briefly mentioned about the biology. There are a couple of other things that that is there in the literature with regards to there is an attempt being made to develop psychometrically strong measures of positive psychosocial factors and outcomes, as well as positive psychiatric interventions, including preventive ones. But what appealed to me is the biology, the biological constructs, and that is quite a exhaustive biological constructs which are there in terms of positive psychiatry. So there is a very good amalgamation between the two. In terms of allostatic load, you mentioned about the telomere length, then oxidative stress, neuroinflammations, immune functions, candidate genes, and a very robust neuropsychiatry for each and every, like for resilience, there's a neurocircuitry pathway. For optimism, there's a neurocircuitry pathway. So it's really fascinating. And we have a very, very interesting topic for the debate today in terms of, that whether positive psychiatry is applicable in private practice in India. So the motion is positive psychiatry, not pragmatic in private practice in India. And for the motions, we have Dr. Vishal Chabra and Dr. Posama Chowdhury. And against the motion, we have Dr. Ajit Vide and Dr. Rutseda Saida. So without further ado, I will invite Dr. Vishal to set the motion rolling. And you have 5 minutes. So each speaker would have 5 minutes. And at the end, you can choose between the two of you who would do the rebuttal for approximately 2 to 3 minutes. The lesser, the better. But, please make a start, Dr. Vishal. Thank you.
Dr. Vishal, unmute yourself. Please unmute, Dr. Vishal.
Thank you, Dr. Abhi. Good evening, everyone who's joined in from all over India and the world. Dr. Patel, you made an excellent presentation. It was very nice. Thank you, Dr. Ranjan, for inviting me for this panel discussion and giving me the tough task of, debating this thing. So, positive psychiatry, the definition which has been given to us is the science and practice of psychiatry that seeks to understand and promote well-being through assessment and interventions aimed at enhancing behavior and mental wellness. Now, if I'm the way I'm doing psychiatry, the way psychiatry is taught to us, the way I see psychiatry evolved in the last 20 years since my training in Manipal, I see psychiatry itself evolving. So the psychiatry we are practicing today, we're not just looking at removal of symptoms, but we are looking at proper, rehabilitation of a person back to a normal living. So, but the amount of work which is required for rehabilitating a person back into normal living, of a schizophrenic or a bipolar, it requires a lot of intervention. It requires a lot of teamwork. It requires a lot more staff. In private practice in India, if you see, not from the tier 1 cities, but look at tier 2, tier 3 cities, a doctor is seeing anywhere between 30 to 40 to 50, sometimes 100, 150 patients a day. To talk about these lofty ideals of positive psychiatry does not make sense there. Also, the training which is done in psychiatric curriculum as of now is to look for the problems, the symptoms, and treat the symptomatology. Overall, there is a trend, I agree, towards better rehabilitation, proper rehabilitation, functional recovery in most patients. Our medicines are becoming better for that. Our medicines are not geared for lesser side effects, for better functional recovery. But if you look at the practice, the way practice is done in India, the amount of workload we have, the deficiency of psychiatrists in various parts of India. To talk about these lofty things is not very practical. So we need to remember that till we have a better patient-doctor ratio, till we have better or shorter interventions, quicker interventions to help our clients, I don't think so just talking about positive psychiatry is going to work in India. This is my shorter start. Or Dr. B.
I didn't expect you to stop so soon. So anyway, yeah. So you mentioned about the quantity of patient, basically the patient load, then about our training, which is more disease model predominating.
Yes.
You use a strong term about being a very lofty idea, positive psychiatry, and we need shorter intervals of interventions for positive psychiatry to at all work, and this wouldn't happen in the near future. That is your take. So let's move on to Dr. Rukseda Saida. She would be the first panelist.
One more.
Sorry. Yes, carry on.
One more thing. I was saying that our medicines are anyways working toward lesser side effects. So they are anyways helping in promoting. Earlier medicines had much more toxic side effects.
Okay.
So the way we will achieve if we do, it will be better medicines and better, faster interventions. That's what I meant.
Right. Yeah, I get your point. Thank you. So moving on to our first speaker against the motion, Dr. Rukseda Saida.
Thank you, Dr. Abir. And thank you, Vishal. I think you've made my job very easy, isn't it? When we talk about positive psychiatry, we've learned so much from our eminent speaker, Dr. Patel. I'm just going to talk about practice. I'm a private practitioner. I'm not attached to any teaching institute. So when I'm looking at what I'm doing on a day-to-day basis, whether I'm seeing, some doctors who end up seeing hundreds of patients on a daily basis, or some of us see only very small number of patients, right? So when I'm looking at my practice, it's both. Yes, it's a treatment center, and it's also a business model, isn't it? And from that, we do need to kind of figure that out. What is it that we should be doing for a successful outcome, both for the patient and for our pockets, isn't it? And in the last decade, we know that the shift from diagnosis focused to a person focused approach of mental illness has necessarily moved to approach of health. We know that from treatment to illness to improving wellness, from absence of disease model to recovery functionality and psychosocial rehabilitation, and further on to a positive psychological function for mental health. We are doing that every single day in our private practice. Private practice in India, by necessity and by the sheer force of will of all of us practitioners, is a one-stop shop. If I don't do this for my patient, it doesn't get done. And if positive psychiatry is not pragmatic in private practice, where is it? It's not pragmatic in a government or a district setup or a municipal setup, isn't it? And then are we saying that, okay, because there's a paucity of numbers, is that we can't do it? But my dear friends, we're already doing it, right? We understand that, okay, when we're talking from a traditional psychiatry point of view, that we're targeting only people with mental illnesses. But in private practice also, just like in government setups as well, we have a patient and a relative come in with them, and we automatically ask, how is everything at home? And we know that just because of especially because of the kind of nature of our work, it's almost like a family practice, isn't it? We do kind of know everything that's happening to them. Not only that, if we have one person coming in from a family, and there's psychopathology and other members as well, they end up coming to us as well. So then our target population also increases and widens, and then there is definitely focus on not just that one person, but also other people who are at risk. And that's positive psychiatry as well. We're not just talking about symptom relief and relapse. When we talk about rehab, do we not ask our patients, oh, have you started going to school yet? Have you started joining work yet? Who's taking care of finances? Oh, who's doing this? When are you getting married? Are you planning a child? What are you going to do? Don't go off medications when you're planning a child. So we are any way doing all of that. So how is it now that we are turning around and saying it's not pragmatic? And Dr. Vishal rightly said that, yes, psychiatric medications have a lesser side effect profile. That's beautiful. But we also know that, okay, they could also be protective and help in neuroplasticity. So even just by writing a prescription, I am practicing a little bit of positive psychiatry, isn't it? When we talk about resilience, we know that it's not just a psychological kind of word thrown around. It's not just a defense mechanism, but it's a brain function. And that's what we say. A patient with relapse comes in and they say that, oh my God, am I ever going to get better? And don't we say that, you know what, remember, you did get better. So why don't we start treatment again? And this time be compliant and you will get better again. If that's not, focusing on resilience and reminding of the resilience and encouraging resilience, what else are we doing? We not only do crisis intervention, but every single follow-up is supportive therapy as well. That builds up optimism. It builds up personal mastery. There is social engagement. We ask them, we're looking after their physical health. We ask them, oh, are you walking? Is your lifestyle better? We ask them, okay, what are you doing for yourself? We ask all of these things. And when we're asking this, we're encouraging them to do that, isn't it? We talk about the family dynamics. We figure out the social support. We encourage them in social engagement. All that is positive psychiatry, which we're already doing on a day-to-day basis, even if we're not measuring outcomes in terms of positive psychiatry, but we are doing the work. And that clearly says that it is doable. And when we are talking about prevention, and like I said, I'm purely from private psychiatry. I don't know a single psychiatrist who hasn't done an awareness campaign, who hasn't done a school or a college or even a corporate talk. And that's about awareness building. We teach them about good mental health practices. So we're talking about prevention as that. And that from a personal point of view, if we don't make it pragmatic, if you're saying that it's not possible for us to do private practice, then are we not essentially opening the doors to more quacks that are drowning out the voice of science? They're not only just like, previously we used to have only faith healers to deal with. Now we all have these quote unquote motivational speakers. Apparently there's no qualification that I need for being a motivational speaker, isn't it? And what are they doing but not advocating positive psychiatry and preventive psychiatry? When I was speaking to Dr. Shah Abhiyam, and who was instrumental in bringing Dr. Dilip Jeste.
One more minute, Rikshada, please. Just a minute more.
So we've been learning about positive psychiatry under Dr. Dilip Jeste for a long period of time. And in 2019, I spoke on from illness to wellness as an invited talk for West Zone of IPS. And that's where we're talking about this, that we are in the era of promoting illness care based on wellness and well-being, with recovery as a key concept. And we must fashion ourselves accordingly. And we are already doing that. And Dr. Vahia just said that, habitually we ask the patient, what is wrong with you? Try asking what is good about you. And that's also positive psychiatry, isn't it? And instead of being focused on problems, focus on happy moments. So, and I'm going to continue learning from Dr. Vahia, and I'm going to practice that. Whether we're talking about perinatal mental health, whether we are talking about resilience building, whether we are talking about, just like Dr. Patel said, from a microscopic approach to a telescopic approach, whether, all of that we're already doing. So clearly, when we're already doing it, it's possible for us to do it. And the outcome, like I said, that I'm looking for is the validation that one patient will bring in another patient, isn't it? And clearly we're doing something right. And that's why all of us are doing very well in our individual practices. My time's up and I cede the floor to the moderator.
Thank you. Thank you very much, Dr. Seda. Well, you have covered a lot of areas. I mean, the essence was that we are already doing positive psychiatry in all our fields of work. So our focus has shifted from outcome to person-centered to positive psychology to psychiatry. It's like private psychiatry is like a family practice which focuses on the whole family. There are broad psychosocial environmental constructs which we already follow. We focus on resilience, optimism, and all the other qualities which we have mentioned in positive psychiatry. So the essence was that we are already doing it. Thank you. So now moving on to Dr. Posama Chowdhury, on Posama Di, and she would be speaking for the motion again, our second speaker for the motion.
Thank you so much, Dr. Abir. After the two excellent speakers, I'll talk against the motion, and I'll just quickly share a screen if you allow me.
Yes, sir. Yes, madam. Function.
Yes. I'll do it very quickly. Can you all see the screen?
Yes, please.
Okay, so positive psychiatry is here to stay. There's no doubt about its importance in psychiatry practice. But in today's debate, my job is to debate the practicality and feasibility of positive psychiatry in our clinical practice. And as an argumentative Indian, it's also my business to raise some doubts about the unconditional acceptance of positive psychiatry as a tool in psychiatric practice. As has already been mentioned, we know that there is a staggering gap. Overall, 83% of people with psychiatric illnesses do not get treatment in our country. And in some cases, the percentage is much higher than that. 83% is just the average figure. And we all know what a minuscule amount of our already meager health budget is allocated to mental health. So, at this juncture, talking about positive psychiatry for all, we are talking about everyone, not just city-based practice or something. Is it more like asking people to have cakes when there's a short supply of bread? That's number one point. Then we move on to the second more important point. That's the question of evidence. Yes, we are all talking about positive psychiatry, and it all began with positive psychology by Martin Seligman in the late 1990s. But overall, what is the evidence base? There are plenty of studies around, but in the preparation for this debate, as I was going through the evidence, there are, I went through a few meta-analysis. For example, this one, which came up in BMC Public Health in 2013. If you can look at the results, I have just highlighted them. The effect sizes are small. Heterogeneity was rather high. Basically, different people are, they're not, outcome variables are not always clearly defined if you go through these studies. And finally, there is a significant publication bias. How many studies do we come across which say that positive psychological interventions are not effective? It is not to say that positive psychology is something that does not have an evidence backup. But before we go on to say, in an emphatic way that positive psychology is here to stay, I think we need more evidence. I was going through the previous issues of Indian Journal of Psychiatry, our own journal, and I couldn't find that many studies. There was a study on resilience, but this one I found this was a better study. I felt this article came out in the Psychological Studies in 2015. It's by Anindita Ghosh and Amrita Deb, two authors, and they have given us, you can see, the progress of positive psychology in India and what accomplishments have been taken so far. There is something known as a replication crisis. You can find plenty of studies where maybe interventions like gratitude exercises increase our happiness. Very good. But then there are few studies that really replicate this. There is a concept called Replication Index. And I'm afraid that this replication index is not very high. For the most prestigious journal, the Journal of Positive Psychology, the replication index brings it to roughly a grade C, not a great achievement that way. Those studies are not replicating themselves. They will replicate in the future. But as of now, where we stand, the evidence probably is not that high. I'm open to debate. I'm sure there will be rebuttals and counter rebuttals, and we're here to discuss that. What I want to say is that it is much easier to have flashy headlines like this one in the Time, or having, the world's happiest nations is Finland, or Bhutan has a very high, economists are talking about happiness index, but having flashy headlines and doing painstaking research are two different things. This is where we probably lag, and we have to do more research, the proponents of positive psychiatry. And the last one, which I feel is also very important, this is the third point that I am making. The commercialization of positive psychiatry. Like Ruxeda was saying, there are faith healers, there are motivational speakers around, and they make a lot of money. Let's talk about Hay House, which is a well-known publishing house in the United States, and its promoter, Louise Hay. She passed away in 2017. She was famous. You heal your is that positive affirmations are at the, they can heal a lot of diseases, including Alzheimer's, including dementia. In fact, Louise Hay had famously claimed that she was diagnosed with cervical cancer. She did not go through the traditional treatments. Instead, she went for positive affirmations and also, things like, diet, etc., which cured her of cervical cancer. I just thought I'd end up this presentation with this interview of Louise Hay by, Harvard psychologist Daniel Gilbert. I have put titles for you so that because the audio quality is not so good, but just go through this. She has been, challenged in a number of ways, and let's just see what she tells us.
All sorts of maladies, various thoughts that you say can cause them.
So before you laugh at this video, you must remember this business. People spend like any. This is there in our country as well. I thought this is one reminder that an unconditional blank thumbs up to positive psychology and its principles without, doubting, without raising questions, will be something that we should not promote. And now the floor is open to debate, I suppose. Thank you so much.
Thank you, Posama. Thank you. Well, you began as Dr. Vishal did with the practicality and feasibility aspect, and you quoted the treatment gap. I was wondering it would come at some stage. And then you also went to the infamous quote of Marie Antoinette about the cake and bread issue. And then you moved on to the poor evidence base in terms of, and also the poor evidence replication base in the Journal of Positive Psychology. You were optimistic by saying that it might, in the near future, it might go up, but at the moment it is very low in replication. And you finally ended with the whole issue about commercialization of positive psychiatry. And well, that's about it. So thank you very much. And then we move on to our last but not the least, our very, very experienced Dr. Ajit Vidhu sir for his speech against the motion for the debate today. Can you unmute yourself, please?
One forgets basics sometimes. And I got very excited listening to Posama. Because of the content, I will say that mainly. Thank you, Prathama, for acknowledging the importance of positive psychiatry. I can see that in this season of crossing the floor, we might soon have you over. I must say that the other Mukherjee is not my guru. Banerjee, who is now engineering so many crossings of the floor. But I will say that I enjoyed listening to you, Vishal. I enjoyed listening to Ruksheda's very spirited speech against the motion. And I want to say that positive psychiatry is quite likely to be pragmatic There's nothing unpragmatic about it to my mind. When we speak about numbers and we say that we have to see this load of patients, we are, again, I cannot help remembering our approach to psychotherapy. So many people will tell you that psychotherapy cannot be indulged in, that's the word used, because psychotherapy is an expensive proposition in terms of time and money. And therefore, I get the impression that our medical identity very often gets threatened if we are not reaching out for the prescription pad and a pen and writing a prescription. There are many, many cases I have seen as the old boy, if you remember Animal Farm, who's seen it all kind of thing. I would say that there are so many cases where prescriptions have been written when none needed to be written at all. What you needed to do was reach out, hold a hand, perhaps squeeze a shoulder, perhaps. Of course, keeping in mind my task as the chair of the Boundary Violations Task Force, I'd say that that kind of reaching out metaphorically is tremendously important. And too often it does not happen. And our standard excuses, we don't have the time. I've got to see 30 patients in this much time. How do you expect me to do it? So I will say this much. Vishal, you made the point that the training in our present setup is nowhere near adequate for positive psychiatry, positive psychology. In the big realm that we have of curing people, getting them on track, seeing that there is drug compliance, all that is important, no doubt about it. But that can also, as Rikshit has already pointed out, be colored with a positive psychiatry approach. She gave you practical points, which I think are very difficult to fight against. And I think we need also, in every consultation, to put in a little dose of positive psychiatry. That is what I think is important and very, altogether, too often missed. Prathama, you made the point of the happiest nations and we come fairly down the list, as we have noticed. In many, many measures, we've come down the list. But I don't think that that research is very sound either. You've talked about the fallacies of research, but let's face it, that we are in a realm where research is very, very difficult. We speak about HAM-D and HAM-A scales, but please remember there's a huge element of subjective bias in all our research that goes by questionnaires. And these research, these findings come to us from questionnaires. Let's take a simple example of personality tests. You have tests where you are asked, are you popular among your people? The guy says yes. 30 others need to be questioned about whether this person is actually popular. And they're not likely to say that this person is necessarily popular. That's something to bear in mind. You talked about our budget and the budget allocation for mental health. Budget allocation for health, in which mental health gets a piddly little bit, please forgive my language, of about 2%. Very, very dismal, very, very disheartening. But it has nothing to do with the fact that we need to inculcate respect for positive psychiatry. I was glad to see that you at least had that, unlike Vishal, and that we have to have an element of it in our day-to-day practice. We need more studies. Without a doubt, we need more studies. And Louise Hayes, the person you have chosen to target today, is no doubt a tremendously popular bibliotherapist, if I might call it that, because her books are widely read, widely followed. I know among my patients, about 10 or 12 of them will swear by Louise Hayes, and I'm not defending everything she says. Her disrespect for scientific research is not something I would endorse at all. But at the same time, will I say Louise Hayes is useless? Will I say Scott Peck is useless? Will I say Eric Fromm is useless? I think they do a whole lot of good to a wide range of people, and we can never, never ignore their inputs. Dr. Patel, in his opening address, which was very remarkable, quoted the ingredients of what positive psychology is all about. Positive psychology is about certain positive traits and environmental factors. And all of these, we need to educate our patients about. We need to subtly help them grow in areas of resilience, in areas of emotional control, in areas of emotional growth. And I don't think it's really beyond our reach. Nor are we not doing it. We don't very often realize it. We don't very often give it that label. That's the crux. We are doing positive psychiatry, and Rukshita, thank you for making that point very clearly. We are practicing positive psychiatry very often without realizing it. We are essentially going to look at positive psychiatry as one area of prevention of disease. But it's not just that. We bandy about statements like prevention is better than cure, said by the great philosopher Erasmus, wrongly attributed to the man who made it very popular, Benjamin Franklin. But actually, the study of healthy personalities, and Martin Seligman, Dr. Patel, you rightly acknowledge the great contribution of our friend, Dr. Dilip Jeste, whom we hold in high regard in this country, and Dr. Martin Seligman. But really, the study of positive psychology started with William James, the father of American psychology himself. And very remarkable for me, when I was doing my post-graduation, I read the biography of Abraham Maslow. And he was the guy who said, we remember him for his hierarchy of needs, but we forget that this is the guy who said, why are we looking at disease all the time? As one of the pillars of humanistic psychology, it was Abraham Maslow who decided to study healthy personalities. And he took up somebody whom he looked up to, the First Lady of the United States at that time, Eleanor Roosevelt, who had a fantastic personality profile about, and she had resilience, she had compassion, she had empathy. These are terms which we now so boldly put forth as aspects of positive psychology and positive psychiatry. These were studied as long as almost 65 years ago by Maslow himself. I will say this much, that a clever person solves a problem. A wise person avoids it. And that is what positive psychology and positive psychiatry are all about. It sounds very clever. It's not mine. It's a great Albert Einstein who had that statement to make. Thank you very much, Abir, for your indulgence. And I forgot to pay my obeisance to the pantheon of IPS, President, Vice President, Secretary, Editor, Treasurer. Thank you, gentlemen. And thank you, Dr. Jayendra Patel, for setting the ball rolling in such a magnificent fashion. Thank you, Ranjan, and the entire Professor Vidyadhar Neil. I'm sorry, I don't remember. Gautam spoke to me and got me recruited for this program, and Ranjan had not yet succeeded. It's been a pleasure being here, and I look forward to the rebuttal of our claim. There will be rejoinders. Unfortunately, that's the way a debate goes. Thanks.
Thank you. Thank you so much. Thank you very much. So again, I think it was, whether it was my system or something, there was some kind of disruption. So I could hear bits and parts of what you said. But again, you mentioned about pragmatism. You mentioned about reaching out in a metaphorical term. And one important thing that you really mentioned that was very, very good was that little dose of positive psychiatry in every consultation. You made a point in 2 occasions about this. And although we are low in our resources, only 2% of the health budget goes for psychiatry. But still, if we are aware of what positive psychiatry is, if we are aware of what the great psychologists of the past and even Abraham Maslow has promulgated, then we would make an attempt to include positive psychiatry in our day-to-day clinical practice in little doses. So that was, what was the crux of what you wanted to, see. That's what I understood. So moving on to the rebuttal. So who would do the rebuttal from the for the motion side?
I want to do
yes.
it.
Okay. Dr. Vishal, please carry on.
So thank you, Dr. Ajit and Rukshida and Dr. Prathama. Really nice. Dr. Ajit, very nice to hear your views, sir. I wanted to talk about, this thought just suddenly flashed in my mind. You're very right there that from the early days of psychology, psychiatry, people are talking about going positive. Isn't that the whole point of medicine and whole point of psychiatry is that we are trying to treat the person, take the person from the disease to a good state, from illness to health. And obviously WHO has revised the definition of health itself of, not just the absence of disease, but the complete wellness, spiritual, physical, mental, and social, and all that. When we talk about positive psychiatry, do we also talk about negative psychiatry? What is negative psychiatry? That's a thought which came to me. Is there something called as negative psychiatry? There is no negative psychiatry. We are doing psychiatry, which is positive. It's just that it's a euphemism. The fact this was started because psychiatry was receiving a lot of flack in America, that you are disease prone, you're trying to overdiagnose people so that people can take more medicines. And we needed as a community, psychiatry community, to counter that negative marketing campaign against psychiatry. And that's why we came up with this euphemism, positive psychiatry. So, and the definition, the reason I read the definition is, it is the science and practice of psychiatry that seeks to understand and promote well-being. Which part of psychiatry is not trying to do that? Is the traditional psychiatry not trying to do that? Are we not trying to promote well-being of our patients? Do we need to really say we are doing positive psychiatry? Except that it is a marketing term, it's a clever ploy from our side for trying to show to the people that we are also being nice. We're not just trying to overdose people, but we're just trying to we're trying to work for your well-being. And that's the reason I was saying that, yes, even the treatment itself has started. Earlier, when medicines were tested, they were tested as 50% reduction of symptoms that was considered as good medicine. But now we're looking at full functional recovery. So itself, as my colleague, Dr. Prathama, did talk about, that there is no doubt we are going towards positive psychiatry. But currently, to talk about it is more of a marketing term than the real thing. We are not looking at, patients that are coming and say, doctor, I'm not feeling well, do something so that my well-being becomes better. We do diagnose depression and anxiety, we treat them for something. Yes, as you said, we reach out to them and talk to them. In a tier 1 place where I am, like in Delhi, I see lesser number of patients. So I have more luxury of more time. I talk to them nicely and try to make them comfortable, as Rukshita also said, and do wellness webinars as she does and I do, and all of us do who are in this debate. But if you go to Rajasthan, if you go to where Dr. Meel is from, if you go to Madhya Pradesh, Uttar Pradesh, Bihar, Maharashtra, you see doctors are seeing hundreds of patients. The fact that they're using good medicines, even if they diagnose well, they treat them well, that is more than enough. That is positive psychiatry already. That's my rebuttal.
Thank you, Dr. Vishal. So basically, you mean to say that there's no point in pouring old wine in a new bottle. So basically, we are already doing it. What is the point in, again, coming up with a fancy term and increasing the commercial value of it? So that is what the essence of your rebuttal was. So now moving on to Rukseda, perhaps, because Dr. Vide has already thanked everyone. So I would presume that it would be.
I have a request from Rukseda. Abhi to do the rebuttal.
Yeah.
So I'm very glad that we are all on the same side. That's all I can say. Because I just heard Vishal say that actually we are doing positive psychiatry. Therefore, it is not non-pragmatic. Do we really have much to say? But I'll say one thing. I'll say many things, sorry. The opposite of positive psychiatry is not negative psychiatry. The opposite of light is darkness, no doubt. And let us go from tamasoma jyotirgamaya. Let's go from darkness towards light. But the kind of movements that brought psychiatry into disrepute, especially in the West, and then again, I guess mainly in the United States, where you had psychiatric professors taking up the cudgels for anti-psychiatry. Anti-psychiatry is what we're talking about. And they are the people who gave psychiatry. I mean, not everything they said is dismissible, let's say that. We ourselves have not always covered ourselves with glory the way discipline is practiced. All that is aside for the time being. What's important is that traditional psychiatry is important. I'm not saying dump traditional psychiatry. I'm not saying do not prescribe, do all that. But lace it with a dose of positivity, which makes the patient feel good. That feel-good factor is tremendously important. And entirely feel-good is what Dilip Jeste has been talking about. If I remember the title of his seminal paper that came in the Journal of Clinical Psychiatry, he says, positive psychiatry, its time has come. And I think the time has come for us to acknowledge the importance of positive psychiatry, inculcate it, and practice it, and spread the message around. Is positive psychiatry for everybody all the time? Probably not. But it is for some people a very major campaign, a very important mission, like Dr. Jeste and Dr. Seligman. For many of us, it is something we do part of the time. And those of us who have these huge caseloads, I would agree that you can't have much time for that. But as we've already said several times, sorry to repeat myself again and again, we lace everything with a dose, with a silver lining of some positive aspect to take home. If not for every consultation, for every patient at least. See that we indulge in it. That's all I have to say for the time being. And I'd leave it to the House to choose whether, by the way, I have 2 opponents and 2 negatives make a positive. My case for positivity rests.
Thank you. Thank you so much. So yes, well, you clarified on the point of it's not negative psychiatry, but it's about anti-psychiatry. And we really had to, sort of somehow go against that, go against an anti-psychiatry. And that is how we promote positive psychiatry. And you did again mention about, infusing positive psychiatry in our day-to-day practice. So, well, for these debates, it's difficult to choose a winner because everyone is a winner, number one. And number two is there's no point in, because we have 2 separate platforms, whereby, that one platform is joined by the faculty and another platform is for the other people. So we really can't have a show of hands.
Choose the winner. We are clearly the winners. You can choose it, no problem. Vishal and Pratima definitely won't feel bad.
No. I think we are all 4 on the same side.
Well, they did concede to us, so that does make us the winner, isn't it?
No, we didn't. No, we didn't. We don't do Dadagiri.
The proponents for the motion only mentioned that we already have a positive. What's the point in having a different name? So that is what I wanted to say. And they had a very strong point with regards to commercialization of this whole idea. So so they had their points as well. It wasn't a clear win. So it was both sided. So I wouldn't choose a winner. It's not fair for a moderator to do that. It would have been for the House to choose a winner. So moderator's role is to moderate. Moderator's role is not to be partial. So I wouldn't choose a winner.
So we'll put the screws on Ranjan then, isn't it? That's what you're saying. Abhi, Ranjan is completely throwing you under the bus.
This is a moderator's job. Moderator's job.
Ranjan announced to us about the International Day of Tourism. And I don't know, Ranjan, whether this can be made public knowledge. He is right now in Darjeeling. He's very sincere, very, very supportive of whatever International Day we are observing.
Yes,
See, I would be happy to concede defeat, but like we said, nothing should be like we should doubt everything.
I think whatever it may be, my suggestion today we have a very esteemed speaker, Dr. Jk Patel. Let him to decide.
Yes.
Right, Ranjan? Abir?
Yeah, of course. Well,
we're going to put everybody on the spot. So why leave the poor speaker?
Dr. Patel, please.
Dr. Patel, unmute yourself.
Do on behalf of Indian Psychiatric Society. You do, please.
Thank you so much. I was just mesmerized by all the wonderful discussions that all of you brought to the table. I was genuinely pleased and reassured by the things that I did not cover that you guys were able to cover, especially the contribution of Maslow and how the whole concepts and everything started. I think when it comes to India as a culture and as a country, we cannot forget that economical issue also. People do need to make money. They do need to make money, and they have to see the number of patients that they do. I think the wisdom comes from how to accommodate to that. So, are there things that you can give them as a handout? Are the things that you can just audio tape and put it on WhatsApp for them, or whatever kind of ways in which you can send the message. If there is a will, there will always be a way to do that. The second part of it is that was being discussed was about the negative psychiatry. Psychiatry has got lots of skeletons. One of them being when we were doing the lobotomies, the time when in Russia we were labeling people as having mental illness, the whole homosexuality and how it was pathologized. And when we talk about commercializing positive psychiatry, I wish that there was a pharmaceutical company who would own up positive psychiatry and promote it, because they have done a marvelous job when it comes to promoting all the antidepressants and antipsychotics. And they have done it so well, the patients will come and say to you, sir, what about that Latuda? I think, I would like to try that kind of a thing. So basically at the end of the day, the question is, how do we validate our patients? When the patients will not share with you all the over-the-counter stuff that they are eating or taking, they will not share with you all the things that they are getting from wherever, because they know that you will not approve of that. How do we validate them and allow them to bring it up? If they say that I'm using Sarpagandha for so-and-so, we could say, okay, let's work with it. Let's find out how effective it is for you. But if it is not effective, can we stop and go to something else? Again, one can say that Indian patients can be classified as rural and urban. The urbans may be more receptive to this and rurals may not be. But at the end of the day, do we have the language to reach out to the rurals? Are we able to articulate the need for therapy to the rurals without making it too psychological minded? Again, these are all challenges, and there is truth in what both sides say so eloquently. And I think the winner, it will be very politically correct for me to say winner is everybody. I think the winner really is the patient. Today, if even 10% of the people are going to employ or put in practice positive psychiatry, which is not just being nice to the patient. Again, you can be nice to the patient. You can serve them coffee and biscuits and things like that. It is about being able to affirm and be with them in their experience and promote their strength while dealing with their weaknesses or their shortcomings. So I would say at the end of the day, it's the patient who's going to win. And I'm so thankful for all of you for the way you shared your experiences. And I loved those slides, Prathama. Wonderful, awesome slides.
Thank you.
Thank you. So I think I'll just make a final comment. I mean, what fascinated me as well as Dr. Patel had said, but apart from, I'm also fascinated by the biological psychiatry. So this whole concept about the allostatic load and this, this is pretty workable. I mean, you can, it's not in the realms of neuropsychiatric circuitries and the pathways in the limbic systems, allostatic loads, and maybe in the distant future, we'll have neuroinflammation, we'll have all those markers, we'll have the cortisol markers and everything. And if we have measurement scales to measure resilience and optimism, and then sort of tally it with the allostatic load, tally it with the telomere length, tally it with the neuroinflammatory markers, well, we have a positive future ahead in terms of serving our patients as well. So yes, so hats off to positive psychiatry, and everyone is a winner in terms of the debate.
Right.
Thank you.
Thank you so much, Dr. Abir Mukherjee, the moderator of the debate session, for this wonderful and mesmerizing session as mentioned by Dr. Jk Patel sir. So 300 years back, when the Franz Anton Mesmer term that coined the term the animal magnetism, similarly, we have been almost hypnotized for the last 120 minutes. And probably this is the first Indian webinar which has started on time and finished on time as promised. So maintaining very tight schedule. Thank you so much for all the speakers and panelists who have joined across the different parts of the world, from USA from Gujarat, from Rajasthan, from Kolkata, from Delhi, so on and so forth. So we had made a really virtual tour on the World Tourism Day. So every good thing has to come to an end. I'm really indebted to all of you. The things have started when Gautam Shri Samin sir has repeatedly asked me to organize this webinar and have given me the full liberty to select the speakers. He himself talked to Dr. Jk Patel sir. And thank you, Dr. Vidyadhar Mil sir. We met in the midterm stream in the IPS in the New Delhi, and we had spoken at a stretch about this program. Thank you, the IPS office bearer, Dr. Gautam Shah, President, Dr. N.N. Raju sir, Vice President, Dr. T.S.S. Rao, Honorary General Secretary, Dr. Otpi Singh, Honorary Editor, Dr. K.K. Mishra, Honorary Treasurer, and the team, Positive Psychiatric Task Force led by Dr. V.D. Milsad, Chairperson, Dr. Sanjay Kumar, who has not been able to join from Muzaffarpur, Dr. Gautam Shri Shamin, Convener, Dr. Arnab Banerjee, the Advisor, and the esteemed panelists and speakers and moderator, Dr. Jk Patel, Dr. Saida Rukseda, Dr. Vishal Chabra, Dr. Ajit Vide, Dr. Posama Chowdhury, and moderator Dr. Abir Mukherjee. Let me discuss one more thing. It will be injustice if I do not mention the team of Symbiosis subdivision of the Sun Pharmaceutical, especially Mr. Arnab Ghosh and Mr. Shudip De. So whenever we have planned this program 14 days back, just 2 days after, Mr. Arnab Ghosh has severe acute abdomen and he has to have been hospitalized, and it has been detected a retrocecal appendix and he has been operated. Still, before going to the OT, 2 hours back, he ensured that everything will be spot on and everything will be taken care of. Thank you, team Symbiosis subdivision of the Sun Pharma. Thank you, Mr. Arnab. Thank you, Mr. Shuripde, for this wonderful team effort, and Digital Infomedia, our digital partner of this program. So with this, I conclude the session. Once again, folded hand, I am extending my sincere gratitude to all of you from the bottom of my heart for joining us today. So thank you and good night from all the speakers and panelists for India, and very good morning, a very bright day for Dr. Jk Patel sir in US. Thank you so much.
Wonderful job, team Positive Psychiatry.
Thank you.
And all of you. Thank you.
Thank you.
Thank you. Good night.
Thank you guys. Thank you. Very nice.
Thank you, Ranjan. Thank you, everybody.